I'm very excited to share with you my thesis regarding characterizing and predicting visual outcomes in adult fulminant and pediatric idiopathic intracranial hypertension. And so, kind of an overview of what we're going to do today. I'm first going to introduce idiopathic intracranial hypertension. And because that is a mouthful, I will be referring to it as IIH throughout the rest of this presentation. I will then be discussing our three major gaps here in the literature. So prevalence of IIH, fulminant IIH, and predicting poor visual outcomes. And then lastly, I'll just review with you the other analyses and future directions for research. So first, just to introduce what is IIH. And so IIH is a diagnosis of exclusion. So what that means is that patients have to undergo multiple tests to confirm that they have nothing else wrong with them. So we have to confirm patients don't have any brain tumors, hydrocephalus, anything like that. So we'll do an MRI. We also must confirm that they do have an elevated intracranial pressure. So we have to perform a lumbar puncture. And then that cerebral spinal fluid also has to be clean in the sense that there's no other signs of infection or disease as well. And then if you meet all that criteria, then you will get the diagnosis of IIH. And then just bringing up my laser pointer here, I want to briefly discuss what is papilledema, because I will be using this word a lot today. And so when we think about the optic nerve, this is truly an extension of the brain, and it is surrounded by cerebral spinal fluid. When an IIH patient presents, they typically have the swelling of the sheath, meaning that there's too much cerebral spinal fluid around the optic nerve, compressing it. And because the optic nerve is a true extension of the brain, once this nerve is damaged and atrophy has occurred, we cannot get vision back. So it's important that we catch this quickly and we're able to treat it quickly so we can avoid atrophy of the nerve. So IIH is rare, chronic, and costly. This is a rare vision-threatening disorder that typically patients have chronic debilitating migraine pain with. It's typically 90% females of a reproductive age, and the majority of our patients are overweight or obese. Other symptoms include back pain, cognitive disturbances, dizziness, and more. IIH also has a significant disability and cost. In fact, even mild visual impairment has been shown to impact overall quality of life for patients. And typically, these patients have a headache-related disability. In addition, patients typically have a quality of life comparable to that of multiple sclerosis, and patients have been known to have increased rates of depression, anxiety, and a 6 times higher rate of suicidality. There's also significant cost burdens with this diagnosis, with patients typically having a 38% increased hospital admission rate, and it costs over $444 million in 2007 in the US alone. Now, from other predictions from other countries, we're predicting even higher increases through 2030. So first, I want to review the major knowledge gaps that we will be discussing today. First, prevalence data is rarely reported in the setting of IIH. And without this data, it is very challenging for us to understand the true impact of IIH on the United States. There's an estimated incidence in reproductive age women ranging from 5 to 49 persons per 100,000, and it's only predicted to increase with the obesity epidemic. There is a true need for higher quality epidemiology studies to characterize and inform healthcare and policy research. And importantly, I want to make sure to note here that at this time, there have been no racial or ethnicity differences in prevalence in the IIH in the United States. And so then we're going to be talking about fulminant IIH. Now, this is a rare presentation of IIH that typically presents in about 3% of all IIH patients. And it's characterized by patients having initial symptoms within 1 month, and within that 1 month time frame, they have to have rapid degradation of vision that can happen over several days. So this is a very rare and rapid and aggressive form of the disease. The gold standard study we currently are using to guide our clinical practice is actually a case series of 16 patients where all the patients are female, they all had headaches, they were all overweight or obese, they 50% remained blind and 50% had severe vision loss. So everyone had significant vision loss and all of them required surgery. And I want to mention here some of the treatment options for IH because we will be discussing this briefly. So traditionally for an IH patient, if they're overweight on presentation, they will typically be recommended to lose weight and take acetazolamide or topiramate. But for patients, such as fulminant IH patients who are undergoing rapid visual loss, there are 3 categories of surgery we'll be discussing today. And that includes optic nerve sheath fenestrations, shunting procedures, and stenting procedures. Stenting is actually the most recent surgical invention for IH, and we'll talk more about that later. So importantly here, further research is needed to evaluate fulminant IH and its surgical treatment options, because again, currently we're using that case series to guide our clinical practice. And lastly, there are limited research on predictors of poor visual outcomes. And this is needed because prompt diagnosis and intervention is vital to prevent vision loss and blindness. But currently, we lack tools to predict visual outcomes at diagnosis. The current only known predictor is poor vision upon presentation, but we've only ever seen about 10 studies that have evaluated predictors in general in the setting of IH. Only 1 study has evaluated predictors in a pediatric population, and the majority of these studies have a small population of less than 100. And so we really require larger studies and further validation of our knowledge in this area. And again, I want to emphasize here that no studies have ever been conducted to predict a fulminant disease presentation or visual outcomes in these presentations. So our summary of gaps here, we're going to review the prevalence of IH in the United States. We're going to discuss fulminant IH and appropriate treatments, and we're going to evaluate studies and predictors of poor visual outcomes. And the purpose of my dissertation is to characterize adult, fulminant, and pediatric IIH whilst creating a machine learning algorithm predicting visual outcomes. And again, why is this significant? We do require prompt diagnosis and intervention for these patients to prevent vision loss and blindness. But again, we don't have the validated tools currently for this. And if we are able to predict vision loss, then we have the potential to reduce blindness in IH, improve patient overall quality of life, improve overall hospital costs, and hopefully improve readmission rates in patients as well. So jumping into our first gap where we're discussing prevalence of IIH. So for this study, we utilized a large aggregate healthcare platform called TriNetX. And at the time of this analysis, there were over 85 million Americans present in this database. And we evaluated the prevalence of IIH from 2015 to 2022, while stratifying by sex, age, race, and ethnicity using this large aggregate platform. We also had a strong inclusion and exclusion criteria because, again, a reminder here, IH is a diagnosis of exclusion. So we wanted to confirm that our results weren't tampered with, like potential brain tumor patients or patients who did not have idiopathic intracranial hypertension. And we found some very interesting results. So IIH had a 35% increase from 2015 to 2022. And what we found most surprising is that Black females had the largest prevalence value here. This was followed by Hispanic females. And then lastly, we see the total female and the white female population. So all these red lines are representing the female populations, and all the blue lines are representing the different male populations stratified by race and ethnicity. And so we can see for males, they're typically staying the same. There doesn't seem to be an increase. It's ranging between 0 and 5. We don't see too much of an increase, but we do see this increase, especially in the Black female population. And I wanted to just touch on 2 significant age groups and some findings we found that were really interesting. So we first evaluated a pediatric group between 11 and 17 years of age, and we found a potential 5-fold increase in patients by 2022. And again, we see that the white and Black females appear to be most impacted at this age group. We then evaluated which group had the largest prevalence overall, and that was 31 to 35-year-old. And we were not surprised by these results. Again, this is a disease of reproductive aged women. But what was surprising by our results was that Black females had the largest prevalence here at 62 Black females per 100,000 Black females in the United States. And this was followed by our white females and our Hispanic females. So overall, we identified when comparing to a white female that Black females had a 66% increased odds of having IIH compared to being a white female, and Hispanic females had a 33% increase of having IIH. So overall, some conclusions from our initial study. We found that IIH increased 35% in the last 7 years. We found that Black and Hispanic females appear most impacted by this condition, that pediatric patients had a 5-fold increase in prevalence, and that male patients continued to have a low prevalence of IIH. And now we're going to be switching gears here. And for the rest of the analyses, I'm going to be utilizing a different database that I'll explain to you how we built through the COL-I records. And so our GAP2 is all about the zebra patients or the rare patients of IIH or fulminant IIH. And so first, our group decided to do a literature update to really evaluate what do we actually know about fulminant IIH. So we tried to perform a systematic review, and I say tried because the only evidence that is out there is case studies and case series that are currently published. And so when we look at the quality of evidence, the bottom of the pyramid here shows case studies and case series, and we need to start building our first observational studies and then ideally more prospective studies to better understand and care for patients and really create evidence-based medicine. So in our analysis, our narrative review, we found that no prospective or retrospective studies had been conducted on this presentation, and we really don't understand the frequency in males, pediatrics, and normal BMI patients. So that led us to build our COL-I IIH cohort. And so we looked for any patient that had an ICD code of papilledema or IIH, and we had over 4,000 patients between June 2012 to September 2023. We then hand screened every patient to confirm if they truly met the diagnostic criteria for IIH, for which we found 719 did or had enough records to confirm diagnosis. And then of those 719, we further confirmed that only 24 had fulminant IIH, which led us to a 3.2% incidence rate. And I want to briefly mention how we're going to evaluate one of our major outcomes in these analyses. So this is defining poor visual outcomes. So patients have a central vision test and a peripheral vision test, and we utilized a binary scale combining both of these. So patients who had a periphery better than a -7 mean deviation scale, they were considered to have a good visual outcome. And if they had a best visual acuity between 20/20 and 20/80, they were considered to have a good visual outcome. Now, if patients had a mean deviation worse than -7, or they had a best visual acuity of less than 20/80, this was considered a poor visual outcome. And we developed these scales based on prior randomized control trials done for IIH, as well as the CDC records for what they consider good and like small visual loss and moderate and severe vision loss. So that's where those numbers came from. But I want to dive in a little bit more to explain what a visual field test is, because we will discuss it a lot. So this is a visual field machine where a patient would sit their head in the machine and their periphery vision would be evaluated. Now, this is important in the setting of IH because typically these patients will lose their periphery vision first and their central vision last. And another reason we created this binary scale was for patients who had high significant vision loss, they might not be able to perform either test, a best visual acuity or a visual field test. And in those settings, or provide like that numeric marker. And in those settings, if we only use the numeric test, we would actually be excluding the patients who have the most vision loss. And that would be selection biasing our results. So that's why we created that binary scale to allow patients who were too blind or had too much vision loss to be included in our overall analyses. And so when we look at visual field tests, I wanted to give you an image to kind of give you an idea of what this test will tell you. So this is typically a normal eye. This is the natural blind spot, that little grayscale there. And we can see that overall it's a grid. This would be central vision here, but there's not too much gray. It looks good. Now, that -7 marker I keep mentioning, that -7 mean deviation, this is where we start seeing a lot more gray and a little black here. So we're starting to see a periphery visual deficit. And this was our marker for anything worse than -7 was considered a poor visual outcome. So just to give you an example, if a patient had a -11 mean deficit here, we'd see a lot more gray and black. And then this is a patient with like a -26 mean deviation. So we can see lots of black and lots of gray. And in the setting of fulminant IAH, you can actually go from here all the way to that -26 in days. So it's really important that we catch this disease quickly so that we avoid the significant vision loss. And again, that would be permanent vision loss once the nerve itself has atrophied. And so that led us to our study, longitudinal visual outcomes and risk of papilledema recurrence in fulminant IIH. Now, the purpose of our analysis was to conduct the first analytical study of fulminant IIH while characterizing disease, treatment, and visual outcomes. We also evaluated time and incidence of papilledema relapse. And so just first looking at some demographics here, as we anticipated, we had a high BMI mean here for all of our patients. All of our patients had a headache. But what was interesting is that we found that we had 3 male patients with fulminant IIH, again, showcasing that this can happen in other atypical IIH populations. We also found that the majority of our patients were Black, and this had not been reported before. And we also found a large amount of chronic and former current smokers as well. In addition, we found about a 30% rate of a history or current anemia, and we'll talk more about anemia throughout this presentation. So when we looked at their final visual outcomes, we first looked at the binary variable. Did a patient have a poor visual outcome? 81% of these fulminant patients did. And then we further characterized it by how many patients had a 2200 visual acuity or worse. Now, we use this scale because this would define legal blindness in this case. So 41% of our patients were legally blind, and 42% of our patients had a moderate visual field deficit. So this would be at least a -7 on that mean deviation scale. So again, the majority of these patients are having significant visual deficits or they're blind. And we then stratified by surgical outcomes and treatment for these patients. Now, I first want to preface this by saying our numbers are too small, so we really can't make any conclusions from this one study. But we do feel like this study is a great hypothesis generating step of what we should be looking at in the future. And so I first want to point out, when we looked at the baseline visual fields, regardless of surgical procedure or no surgical procedure, it did not differ between groups, showcasing that it wasn't that one group had much worse vision at baseline and then received a particular surgery. And then when we look at how many patients had that binary outcome of a poor visual outcome, we found that stenting patients actually appeared to have less poor outcomes compared to having a shunt or compared to having an optic nerve sheath fenestration. So again, we cannot make any firm conclusions from this, but it is hypothesis generating, and perhaps stenting might be a better outcome for these patients, but it is going to require larger cohorts and analysis to confirm. We then evaluated papilledema recurrence rates within this population, and we found overall that 25% of our patients had a recurrence of papilledema after initially resolving. And what was most interesting is, of the patients who had a recurrence, their time to initial papilledema resolution was only 2.5 months, whereas the mean for the entire group was 7.5 months. So for some reason, our patients that have a recurrence are actually appearing to resolve their initial papilledema much earlier than the other patients. So this leads us to hypothesize that maybe we need to watch out for the patients who are quickly recovering because they might be more at risk for a relapse. And then in addition here, we evaluated that overall patients should be monitored for about 8 months after initial papilledema resolution. Again, just looking at how long our time to papilledema relapse, our meeting in our standard deviation. So if we look at these patients for about 8 months, it should be fairly comprehensive for at least this population and trying to avoid or catch a recurrence. Because again, if a recurrence happens, they could still be at risk for significant vision loss. So we need to catch that quickly. So what were our results from this analysis? We first determined that fulminant IH can occur in pediatrics and adults. It can occur in males and females. it can occur in normal weight patients, and 30% of our patients had anemia. And the reason we bring this up is because there's actually been several case studies and series that have evaluated treating anemia coinciding with treating IIH, and they do appear to have potentially better visual outcomes. Why? We still don't understand, but for some reason, we're finding a higher rate here of anemia in this population. So it's just important to note here. It might be important for the future. We also evaluated recurrence rates in patients, and all IH patients, we may benefit from anemia screening and potential treatment. And at this time, we have no conclusions regarding treatment, but we were able to create some new hypotheses for the future. We also were able to publish these practice guidelines, which was very exciting for us. So we recommend that patients who present with optic disc edema require urgent visual field testing, that fulminant IH can occur in patients with a normal BMI, that anemia should be tested for in the setting of IH, and that patients should have a minimum of an 8-month follow-up after initial papilledema resolution to try to catch any potential recurrences of disease. But importantly, as little is known about optimal treatment mechanisms for this presentation, it's going to require multi-institutional and international collaborations for future research to occur. Because again, even in our large eye center, we were only able to identify 24 patients with this presentation. And so going into our last gap here, this is where we're going to evaluate predictors of poor visual outcomes in IIH. So this led to our study entitled Prediction of Poor Visual Outcomes at Idiopathic Intracranial Hypertension Diagnosis using a supervised machine learning algorithm. But our true research question is, can we predict a patient's visual outcomes at the time of their IH diagnosis? And so to do this, we again used our handy dandy COLI electronic health record database. And so we evaluated over 4,000 patients, and we found 719 had IH, of which 391 had longitudinal visual records available. So this was defined as anywhere from 3 months after their initial diagnosis to up to a year after their diagnosis. And then we created 3 different models. So our first model included all the patients, and then we created 2 additional models. And the reasoning for this is we found that baseline vision so significantly correlated with our outcome that we decided to stratify by patients who had baseline poor vision and patients who did not have baseline poor vision to try to understand other factors that might influence poor visual outcomes. So model 2 does not include patients with a baseline poor vision, and model 3 does include patients with baseline poor vision. And so we're going to be doing a couple different analyses here, and I want to walk you through just what those are. So first, what is a logistic regression? This is when we're going to predict the probability of an event occurring based on factors placed into our model. So our inputs are going to include demographics of patients, comorbidities, so different diseases they might have had before their IIH diagnosis, and baseline IIH characteristics, such as like an opening pressure on a lumbar puncture. And then we'll put it in the machine, and our logistic regression will spit out a binary outcome, either yes, a patient is at risk for a poor visual outcome, or no, a patient should have a good visual outcome. And we also utilize decision trees, and this is a form of supervised machine learning that's used to classify and evaluate risk of an outcome. In this case, our outcome is, does a patient have poor vision? And so again, we're going to include the same inputs, our demographics, comorbidities, baseline characteristics. And then our decision tree is going to make a binary decision. So it'll choose a variable to make a decision on, and that will lead to decision 1. And then it'll make another decision. And for instance, you might get at that point a percent at risk for an outcome. So it will keep making these binary decisions to make an outcome. And I wanted to give an example of how this can be used in clinical practice. And so this is an example. It's called the Edinburgh Visual Loss Diagnostic Algorithm. So for example, in this case, the algorithm decided to stratify based on confrontational visual fields. And then if a patient had a monocular visual field defect and they had normal visual acuity, then it would tell us to look at the peripheral retina. So again, we're making these binary decisions to help us identify important attributes here. And so the steps for my analysis. First, we collected the data. we cleaned the data, we performed variable selection, we created and evaluated our models, and then we performed k-fold cross-validation for testing. And I just want to walk you through. So again, we're utilizing our COLE-I IH cohort. We created both logistic regression and decision tree models, with our outcome being visual outcomes reported between 3 months and 1 year after diagnosis. And we did have several overfitting prevention strategies. So we first performed descriptive analyses for all of our models. And any baseline variable that had a p-value of less than 0.25 was potentially included as a potential predictor for the algorithm. This was to be extra conservative to make sure we weren't excluding anything that might be important for our analysis. And then we performed an exhaustive stepwise model selection to best determine which attributes were most valuable for the model. And so this is an example of one of our descriptive tables here. And I just want to highlight a few interesting findings we had. First, we found there was a larger proportion of Black individuals that had a poor visual outcome compared to Black individuals that had a good visual outcome. And this was the same finding for Hispanic or Latino. And it's important because this really hasn't been reported on in the past in association with poor outcomes. We then evaluated smoking status, and we found that there was a larger proportion that had a poor visual outcome that were current or former smokers than had a good visual outcome. We also found, unsurprisingly, that fulminant IH, most of those patients had a poor visual outcome, and that we had a larger proportion of history of hypertension in our poor visual outcome group compared to our good visual outcome group. And so now looking at our models. So again, model 1 is our total model. Model 2, we stratify by having no baseline poor vision. And model 3, we had baseline poor vision. And so 2 things I want to highlight here. For these analyses, we aim to prioritize sensitivity and positive predictive value. And the reasoning for this is that if we had a high sensitivity, this would result in a higher number of patients having a false positive or falsely being identified as having a poor visual outcome. Now, when we're talking about a condition which can be very rapid and cause significant, permanent vision damage, we'd rather have more patients be falsely identified as having this outcome than not, because that would mean that they're going to be having more care by their clinician and more follow-up and screening to potentially look for that drastic vision loss. If they were more that were false negative, we might lose more patients, and therefore more patients might end up with legal blindness. Now, positive predictive value, this balances off of this, and it's the probability that a subject has a disease if they have a positive screening test. So a high positive predictive value would indicate that a test is likely correct. And so that's why we aim to prioritize those 2 values here. And so that led us to our model 1 decision tree, and our model 3 decision tree appeared to perform the best, especially when we look at model 3, we see we have a high sensitivity and a high positive predictive value here. And so this led us to our decision tree. And so right now we're just looking at half of it. This decision tree was able to help us create prognostic risk factor groups where we identified critical risk groups, high risk groups, medium and low risk groups. Now, the first decision that the tree made was a patient who had a baseline visual field of worse than -7. So if a patient had a baseline mean deviation of worse than -7, they already had a 37.5% risk of having a poor visual outcome. So all of the elements in this group are considered critical or high risk patient groups. Now, if a patient at baseline had, let's say, a mean deviation of worse than -9, there was a 69.8% risk of having a poor visual outcome. And what was very interesting was that when we stratified by minority patients, so if an individual identified as a minority and they had a significantly poor baseline vision, then there was a 92.6% likelihood of having a poor visual outcome. And this risk was smaller in our white population. So again, looking at our critical risk, that baseline vision highly determines it, but also if a patient identifies as a minority, this appeared to exacerbate the issue. And so then when we look at the other half of the decision tree, we're looking at a baseline visual field mean deviation of better than a -7. So if you fall into this category, there's only about a 5% risk of having a poor visual outcome. But what was interesting is that when the model placed race and ethnicity into account, if a patient identified as being Hispanic, there was a 23% increased likelihood of having a poor visual outcome. And then if a patient had, let's say, a visual field mean deviation of -3 to -7 in between that range, and they identified as a current or former smoker, there was a 24% increased likelihood of having a poor visual outcome. Now, if they weren't a smoker and they were affected by anemia, this keeps coming up, then there was a 30% increased likelihood of having a poor outcome. Now, our low group here is patients who had a baseline vision of better than -3. Only about 1% had a likelihood of having a poor outcome. And so then this led us to our K-fold cross-validation. And so this is a great testing strategy when you have a fairly small sample size, such as we did, because we can train on the whole sample size as well as test on the sample size. And so we did a 5-fold validation. So what that means is that it takes a small portion about 5 times, and it's going to test on that data, and that will give us an average performance rate. And so that's how we'll determine overall testing values. And so then when we look at the outcomes here and we took this are 2 top models. So we look at the accuracy. This is the average percent correctly predicted. We see that model 1 had 0.9 and model 3 had 0.94. So high accuracy. And when we look at kappa, now this is the agreement between predictions and actual values, where 0 would mean that there is no agreement between the two, and 1 would mean that there is perfect agreement between the two. We see 0.52 and 0.7. So model 3 does appear to be performing better here in the testing scenario. And so what are our overall conclusions from this analysis? We were able to provide clinicians with valuable prognostic markers, such as numeric values to look for on a visual field that can help identify risk. And this has not been done before. We were also able to assist with identifying patients with a critical risk for vision loss. And we found that patients with a mean deviation of -9 or worse had a 69% increased risk of having a poor visual outcome. And this was only further increased if you were a minority patient. So overall, I just want to highlight a few innovations of all the analyses we talked about today. So we were able to determine the prevalence of IH in the United States. We identified important racial disparities within the disease. We characterized IH with one of the largest cohorts to date and the largest fulminant cohort to date. We also characterized fulminant IH and observed papilledema recurrence within the population. And lastly, we developed an algorithm to predict poor visual outcomes in patients. And this made our algorithm more generalizable to all those that had IIH because we included pediatric patients, fulminant patients, and adult patients in our analysis. And I just want to touch on a few other studies we were able to do with our COAL-I cohort here, but I just didn't have time to discuss. So in addition to what you heard today, we also evaluated IH in pregnancy and hypertensive complications within this condition. We evaluated prepubertal and postpubertal disease because they actually present differently in children. We also evaluated longitudinal visual outcomes of IH in men, and we evaluated the quality of life of IH and fulminant IH in patients. And so how do I see all of this impacting research for the future in IH? Well, I think the first key is building strong collaborations with our IH patients. In fact, when we performed our quality of life study, I was actually able to talk to several patients on the phone, and the amount of excitement I heard was pretty miraculous. They were so excited to hear that someone was studying this condition. There is not a lab at the moment that just focuses on this condition in the United States. So it was really great to connect with those patients. So it's important to connect with them also because we need more patient numbers. And I believe that patients really do want to be involved, but there's not many opportunities for them to be involved in their own care and research here. It's then going to require multi-institutional and international collaborations. If the fulminant analysis show you anything, it's that even in a very large center such as COAL-I, we were only able to identify 24 patients. So it will take multiple institutions to really understand surgical treatments and what's best for those patients. Ideally, then, this will lead us to creating a prospective cohort study. and then building a living patient registry so we can really understand the longitudinal impacts IH has on the overall lifespan. And hopefully all of this will lead to improving patient lives. And I just want to end here with just noting some of my long-term goals. So I would love to continue in the rare and understudied disease area, elucidating modifiable risk factors for disease development. And I would love to support and teach and mentor the future generation of scientists. And now just a couple of thank yous. So if you'll just give me a few minutes here. None of this would be possible without my fantastic PIs in the Kobe lab. There are so many individuals in this room and online and others who are in clinic right now, but that supported these studies and just supported me. And I cannot thank you all enough. And especially my PIs, Dr. Talcott and Dr. Singh, who supported me at every step of the way. And they heard my passion about IH and they really let me study this disease I was passionate about, and I'm forever grateful for that. I also want to thank my entire committee for being part of this journey and steering me throughout the last 4 years. Dr. Devin Cohen is our IH expert, and it would not be possible without her support and insight into how this can be used in clinical practice. Dr. Schultz, I would not be able to do any of the machine learning things without your guidance and expertise, so I really appreciate all the time you spent with me. And Dr. Delancey, you've been my biggest cheerleader, so I cannot thank you for steering this ship. So I really appreciate all of your time. I also want to thank my 2 dogs, my writing team, Joey and Rambo, although sometimes they are a distraction. And I want to thank the world's greatest nephews because they just bring a smile to my day, especially after a long day of thesis writing. And none of this would be possible without my incredible family. They have watched my journey throughout the many, many, many years. I actually have dreamed of pursuing higher education and getting a graduate degree since I was 11 years old, and they have followed and supported me since then. So I really can't thank you enough, especially my parents, for just supporting my career. And lastly, I just want to thank my fiance, Mark. He hears me talk about IH every day. He is required to tell me about any patient who has IH in the hospital when he's seeing patients. And really just for being my ultimate collaborator. You push me to be a better scientist every day. And you have taught me so much. And it's just been an absolute joy going through this journey with you. And now I'll take any questions. Yeah, for Zach.
First off, great talk.
Thanks.
And then on slide 42 and 43, I'm wondering, when you had those branches, did you choose those branches or did machine learning choose them?
Machine learning. Mm-hmm. Great question. And Zoom people, you're also welcome to ask questions. Yes, sorry.
So for the kind of, and maybe this is like the next step, so totally okay if you don't know the answers to this yet. Do you think from a minority perspective, the poor visual outcomes are from a like care standpoint, like minority women have a delay to their diagnosis, or they see multiple providers, or they have health insurance issues, or is it assisted with high levels of obesity, higher levels of smoking, higher levels of anemia, any other things that got teased out?
That's a great question. We actually did look into that in our prevalence study. And so we actually found that Black females, this is looking at obesity trends within the TriNetX platform, they had the highest rate of obesity by far. You can see here this red line, they're about at 43 here. And this is percent. But and also in answer to your question, our committee, we've all talked about this extensively, and I think it's one, the association with obesity, but also just perhaps it's taking them longer to get care, and that also might be why they're more at risk for having a poor outcome. I am not a smoking expert, but if smoking really is a risk factor for things like fulminant, I imagine that might play a role in those communities as well. But again, I am not a smoking expert, so I would have to confirm that.
And just to follow up on like when you did your exclusion criteria, I think MS was exclusive. also wondering about like other autoimmune conditions and the association with like autoimmune conditions with black patients. And if there was anything about that. I know you're not small.
No, that's a great question. So we based all of our exclusion criteria on the consensus guidelines created in 2018 for IAH. This is actually done by a UK group. They pretty much do the most IAH research in the world. Fun fact, but they actually recommend excluding lupus and MS because especially when using ICD codes, we want to make sure that these patients have papilledema, not optic neuritis. And so that's why we excluded those groups. We didn't particularly look at any other particular autoimmune groups in this analysis. Yeah. Rachel?
How are you thresholding low iron? Because that's different for males and females. Specific levels. So
Yes, that's a really great question. So one thing to note about our records here is a lot of people come to the center to get IAH care, and they might not have their clinical and their primary care being conducted here at the clinic. So it made some of our records more challenging to review. So we just looked at if they ever had a history of that noted in their chart of any anemia. We weren't able to confirm with lab values. I think that needs to be done. It's just one of the limitations because sometimes our patients go back to their home ophthalmologist. These patients will come out of state here just to get care for their IAH. So that is a limitation, but something I think if we are able to build a living registry would really be able to support that analysis. Yeah, Kristen?
First of all, I thought this was fantastic. I'm so proud of you. Just kind of on more of like a personal journey note, as you went through this, I mean, I know you've been working on this for years. Did anything come out as surprising to you as you were going through this, or did it seem like just one thing led to the next, led to the next, led to the next, or was there like a moment that was like, oh my God, I never thought about that?
Yeah, honestly, there really was not much known on the potential racial disparity. So that I found was surprising. And I also found it surprising that even in our machine learning algorithm, it continuously played a role, as well as anemia and smoking. So we kind of had thought smoking might be a risk factor, but the fact that it continuously popped up in multiple analyses was very surprising for us. But overall, like so when we first designed the cohort, we had an idea for doing a multitude of studies. So it was just really cool and rewarding to see them all come to fruition here. Anyone on Zoom have a question? I'm thinking, no, I don't see anything.
Yeah, Jacqueline, I do. So thanks.
Oh,
I could hear some of the questions, so apologies if I'm repeating some of the stuff. So your kappa was in model 1 was quite low, not better than basically chance. Kappa 2 looked better. Kind of give me some senses on why the discrepancy, between these two numbers, and how do you think kappa could be improved if you had to redo or get more data or redesign something to develop a better kappa?
Definitely. I think that this just really shows that baseline poor vision significantly drives the relationship. We had a better kappa in the Model 3, and when we had the total group in Model 1, that's where we had that lower kappa. And I think that another way this needs to be improved is we had a fairly small group that did not present with baseline poor vision, but had poor vision as an outcome. And so I think if we were able to expand our numbers, this actually might elucidate and improve kappa and just improve our model, because it's very hard to kind of understand those trends when some of our ends were that small.
Yeah, and that was going to be my next question to you was, how do you develop a system by which these patients can come in before all of this happens, right? Because I think that's the biggest challenge here, right? You had patients that obviously sought medical care because they had visual symptoms, and there are probably people sitting out there in general in our communities elsewhere that have this condition, and we don't know that right now.
Definitely. And I think that one of the big barriers is, even if patients are showing up with migraine, my understanding is not all patients are screened for papilledema. And so maybe we need to start just looking at those patients because they already are at a higher risk because IH is so associated with migraine. It is a challenge to get them into clinic. And there's also an extreme neuro-ophthalmology shortage. So I think that having better perhaps better practice guidelines that we can share with even some primary care clinicians. What do you need to watch out for? When do you need to send to an ophthalmologist who can then refer to, a potential specialist care, would be really helpful in these situations. But yeah, Dr. C, that's the $1 million question, because that is a huge challenge that I think we need to better address.